Okay, good morning, good afternoon, depending on where you are today. My name is Saki Malik Cho with the National Center for Health and Public Housing. I'd like to welcome you to the fourth session of the Sdoh Screening Tools for Public Housing Residents Learning Collaborative. Thanks again to all of you for making the time to attend. Today, we're going to discuss integrating screening practices into EHRs and managing workflows, thinking about the practical steps of implementing a screening protocol and also the importance of screening and addressing mental health of patients. And we have a really great guest speaker, Dr. Zara Marsellian, who's the CEO of La Maestra Health Center, to help with that today. In case this is your first time joining us, or if you're viewing a recording of this session, I just want to let you know some background on the National Center for Health and Public Housing. We are a national training and technical assistance provider funded by the Health Resources and Services Administration, or HRSA, to strengthen the capacity of federally funded public housing primary care health centers and other health centers that serve public housing residents. We work directly with housing authorities, health centers, and other organizations to improve access, quality of care, health equity, and ultimately to help improve health outcomes for public housing residents. But the views and the comments that we express today are our own. They don't represent the views of HHS or the federal government. Just some quick housekeeping items. We would like for this to be an engaging and welcoming and informal session. So if you feel comfortable, please feel free to keep your video on. You are muted right now. We'll open that up during the Q&A so you can ask questions freely, but please turn your mic on only when you're speaking. In the meantime, if you would like to be unmuted, just use that raise hand icon and we will unmute you. We've had a lot of great engagement between attendees and speakers, so we hope that continues today. We are recording the session, and the slides in the recording will be posted to Moodle and will be sent by email. I did send out the slides and the recording for last week. If you didn't get that, please let me know. I have been getting some bounce backs on my email, so just let me know through the chat and I'll make sure that we get it to you. Again, the chat is open. We hope you use it. We encourage you to use it throughout the session, as you've done in the previous sessions. While you're listening to the content, add your thoughts, add your questions as they come to you. If you see something, please respond by all means. We're really striving for these sessions to be a place of learning and exchanging of information from everyone. So please share your own experiences and challenges and strategies. This is an opportunity for us to learn from each other. So go ahead now and introduce yourselves on the chat so we can see who all is here today. Please enter your name, your health center, and your location, and welcome again. Also, feel free to log into Moodle to access our recordings and slides and resources. So you all know who we are. My name is Saki Cho. I'm the Director of Research Policy and Health Promotion at the National Center. I'm joined by Dr. Abdi Naboya-Rios, who will be helping to moderate today. My colleagues, Fide Pineda-Sandoval and Chantel Moore, who are helping with the polling and the chat and all of the behind the scenes items. And then I just want to go ahead and introduce our speaker, Dr. Zara Marsellian. She is the founder and president and the CEO of La Maestra Family Clinic in San Diego County, California. From all of her experience, Dr. Marsellian has created this circle of care model of services that goes beyond providing essential health services, and it addresses the full scope of social determinants of health. La Maestra provides on-site housing, application assistance, translation, interpretation services, transportation, a food pantry, microcredit and micro enterprise programs, legal advocacy, and after-school and suburb programs. Dr. Marsellian has written several books on how to provide culturally and linguistically competent care while addressing the many facets of health and wellness. She received her PhD from the University of San Diego, her master's degree from Phoenix University, and an undergraduate degree from San Diego State University. So it's a very great pleasure for us to have her here today. And as you did during the last session, I encourage you to take advantage of this time, ask her any questions about the points that she makes today during her presentation. So here is our agenda today. We are going to do a quick recap of the third session. We're going to do an overview of today's session. I'm going to discuss some of the importance of screening for mental health, and then Dr. Marsellian will be presenting, followed by the Q&A. So last week, Dr. Bethel from Hopkins discussed a pediatric screening tool that she developed at the Child and Adolescent Health Measurement Initiative that uses a cycle of engagement model to promote child and family well-being. She covered quite a bit of information about the tool, which consists of a well visit planner, followed by a relationship-centered patient and provider encounter, followed by a post-visit assessment called the Online Promoting Healthy Development Survey that determines the quality of care and the impact of service delivery on whole families. I'm sorry if this is a little hard to read. It's the 2-pager that I sent to you in my last email that provides an overview of the tool. There's a lot in here. I just want to highlight a couple of her points. And the first is that this model and tool that she has developed is evidence-based, and it aligns with the Bright Futures guidelines. It's a brief survey. It has core domains as well as optional assessments and topics. So there's some flexibility there. It's free. There is a central focus on using the tool to build trust and personalized care with families in mind, with a direct intention of lifting up and celebrating child and parent strengths and supporting and promoting resilience, which is something that I really appreciated. And when she developed the tool, she understood the mismatch that happens within EHRs. So she created these clinical progress reports to help providers have all of the information that they need in one place to improve that interaction. And then finally, it includes a measurement process that's continuously updated and assessing improvements in quality of care. As she mentioned last session, she's very interested in supporting and working with health centers to start using this model. So if any of you would like to take that next step or explore the tool further, just let me know so we can help facilitate that. And now I'm going to pass it on to Abdeen to go over the guiding questions and learning objectives.
Good afternoon or good morning, depending. Thank you, Saki. For this session, we have 4 basic guiding questions. 1, can SDOH impact the mental health of public housing residents, and how? Secondly, how can screening protocols play a role in integrating behavioral health care? Third, to what extent can organizations identify the quality and the type of staffing and resources that are needed to implement successful screening processes? And finally, how can health centers build internal capacity as well as develop community partnerships to address SDOH? And the learning objectives for today, in terms of integrating screening practices into EHRs and managing workflows, are also 4. First, to discuss how SDOH impacts mental health in public housing residents. Secondly, describe workflow protocols that maximize care and is supportive of patients screened for mental health. Also, to identify staffing and resources that are needed to implement a successful screening process. And finally, to describe how to strengthen internal capacity and expand community partnerships to address SDOH.
Thank you, Abdeen. So now we're going to talk about the importance of screening for mental health and substance use disorders. We showed you this slide during the first session, I believe. It provides an outline about how our health is determined by health behaviors, clinical care, social and economic factors, and the physical environment. And typically we focus on the effects of these factors on physical health, but there are also impacts on mental health as well. The stress of living in a house that's falling apart, the worry of mold resulting in your child's asthma attack, worry about not being able to provide healthy food for yourself or your children, or how those unhealthy foods really impact your mood and mindset, as well as the impact of crime and violence or witnessing crime or violence that can impact health. PHPC health centers are more likely to be located in areas with high crime. The average violent crime rate is 508 per 100,000 population in counties where PHPCs are located, compared to 386 nationally. And violence can be in the form of child, physical, and sexual abuse, intimate partner violence, elder abuse, sexual violence, youth violence, or bullying, or witnessing any of those things. And that can result in increased incidence of depression, anxiety, post-traumatic stress disorder, and suicide, as well as cardiovascular disease and premature mortality. I know that most health centers are screening for behavioral health needs. I think the question here is more the quality metric. What percentage of your patients are you screening? And then what percentage of your patients are getting the appropriate follow-up care based on that screening? These are the findings from the Commonwealth Fund's 2018 survey on Fqhcs. And it shows that 26% of health centers are saying, all of our patients are supposed to be screened for emotional or behavioral health needs, but not all are actually screened. And it's not clear why that's the case. It could be an issue of capacity or a need for training and technical assistance, but it does show that there's some room for improvement. And then here are the types of counseling and treatments for behavioral health that are offered on site at the health center. Short-term counseling for mental health usually available, but longer-term counseling less so. And then the treatments for opioids and other substance abuse disorders even less. And I think that we all assume that mental health, behavioral health, those are critical items to address among patients living in public housing communities. There actually isn't a lot of research on the prevalence of mental health and substance use disorders among public housing residents specifically. And UDS doesn't provide that type of patient breakdown, as you know. And in addition to the prevalence of mental health challenges, we at NCHPH are also interested in the needs and the access to behavioral health information or services and the challenges that public housing residents face in obtaining care. So we conducted a small research study in 2019 to try and find the answer to some of those questions, to identify behavioral health status, use of services, needs, challenges, as well as source of care and perceptions of health centers among public housing residents. The goal of this study was to provide feedback and guidance to PHPCs on how to adapt their behavioral health programs to address the specific needs of this population. I'm not going to go over the report in depth. I just want to highlight some of our findings. Some brief methodology here. We developed and fielded a 31-item survey, keeping it as brief as possible to encourage individuals to fill it out. And then we fielded this survey at the National Alliance of Resident Services in Affordable and Assisted Housing, the NARSA conference. This is a conference that takes place every year. Attendees are either public housing resident leaders or they're affordable housing stakeholders, and they come from all across the country to attend. In case you aren't familiar, resident leaders hold leadership positions on resident advisory or tenant boards. They act as a liaison between residents and their local housing authority. They're actively engaged in communicating resident issues, providing guidance, support, performing outreach activities. And then the affordable housing stakeholders that are present at NARSA are typically from housing or social service agencies or serving public housing residents. And so we examined 3 different groups of individuals: those that receive housing assistance, those that receive any kind of public assistance, and that could be SNAP or utility or disability, and then those that don't receive any type of assistance at all. And that was our comparison group. And I'm just curious, if any of you have worked with residence leaders at your PHA, if you have, please just let me know in the chat. These are a wonderful group of advocates. They're very passionate about improving their communities. And they're really a good group to engage and partner with to get feedback. So if you haven't worked with them, I encourage you to do so. But if you have, just let me know in the chat. So I'm going to, again, just run through some top line findings fairly quickly. And I have a link to the report in the resources slide at the end. So if you want to go back and take a closer look, you can do so. So as you might expect, we found that yes, individuals with housing or rental assistance were significantly more likely to report fair or poor mental health status, around 4 times more likely. And they also had a higher prevalence of anxiety and depression. And just for context here, the national rate of individuals that report feelings of depression is around 21%. And you can see that 72% of those with housing assistance reported feeling depressed. So this is just showing you the extent of the problem. And I know that this is a very small, convenient sample. It's not generalizable to all public housing residents, but just a reminder that our sample is consisted of a very highly active and engaged group of folks. A lot of information here on this slide. The take-home point is that roughly twice as many individuals that receive housing assistance report that their anxiety or their depression is interfering with their ability to complete daily activities, such as taking care of themselves, members of their household, doing housework compared to the general population. So mental health is a problem, we've confirmed it, but I think the intention of presenting this information to you today is also to discuss unmet needs. So if we were to focus our attention here on those who strongly agreed that they received enough counseling, we see that only 40% of those with housing assistance strongly agreed that they received enough mental health counseling, compared to 75% without. And we are comparing the gray bar versus the blue bars on these graphs. But they are also more likely to need information on mental health. 42% of those with housing assistance said that they needed information compared to 13% of those without. And for those that are seeking, I forgot about my animations on here. For those that are, only 54% with housing assistance strongly agree that they had received enough information compared to 80% without. So they are seeking information and counseling, but they aren't receiving enough. So why not? What are the challenges that they're reporting? Again, I'm only going to read out the responses for individuals with housing assistance. Close to 30% said that they asked for help, but they did not get it. 11% said that they were afraid to ask for more help. 11% said that they didn't know where to get more help. And then the majority, 50%, said they preferred to manage it themselves. And there are a lot of implications here. Stigma, access. I just want to point out the importance of trust. If close to a third of these individuals are reporting that they asked for help, but they didn't receive it, then that's a real challenge. There's a lot of vulnerability to overcome stigma, bravery to ask for help, and the disappointment of not getting the answers when you're looking for, and it's not inconsequential. Those kinds of experiences add up. So there's a lot that we can do to help provide trust, culturally appropriate care, and improve health literacy out there. I do want to mention that the majority of our sample were visiting doctor's office for their mental health care, while around 17% were going to their community health center. But the majority of them agree that community health centers might be a good place to access care. Again, there are limitations to our data. Our findings aren't generalizable to public housing residents at large, but overall in our study, we learned that mental health issues are more prevalent among public housing residents with a significantly higher need for information, services, treatment, as well as unmet needs that we just discussed, but that the HRSA Health Center program is an important and a trusted source of behavioral health services. And I just want to highlight the relationship between mental health and oral health next. The next few slides come from a webinar that we did with the National Network for Oral Health Access on integrating behavioral health and oral health. Here it's described as a cyclical relationship. Good oral health can lead to better mental health, poor mental health can lead to oral health issues and vice versa. But there are a lot of tangible ways in which these two are related. And this slide comes from Central City Integrated Health, which is a health center that's located in Detroit. And they've laid out some examples of how oral health and mental health are related. For example, how grinding your teeth typically happens when you're feeling stressed, which can lead to dental problems. Individuals with anxiety often experience acid reflux, which can erode teeth, leading to dental problems. People with depression or anxiety can lose interest or focus on their self-care, neglecting brushing their teeth, which can lead to tooth or gum decay. Some psychotropic medications can cause dental erosion. And then those that are struggling with addiction can also neglect their teeth or have poor diet that can be bad for health. So given this connection, the folks at Central City actually include a mental health screening using the PHQ-9 and the CAGE screening in their intake at their dental clinics. This slide outlines their process. The screening is embedded in their forms. So front desk staff enter it into the EHR. If there's a high score, a referral is created. A peer support person comes to the clinic. The clinic staff is alerted about the elevated score. They make sure that the patient has some privacy. And then after the scheduled treatment, providers discuss additional services that are available to that patient. And then they have staff trainings regularly to discuss policies, procedures, and quality improvement. It's a really great example in case you aren't doing that type of screening in your dental clinics. I added the link to the resource slide in case you're interested in viewing that full presentation. You're welcome to do that. So now it's time for us to hear from our guest speaker, Dr. Zara Marsellian. She's going to talk about La Maestra's journey, what she's learned along the way about SDOH and screening and building referral networks to care for their patients. We're going to use a different format here for her presentation. It's more of an interview type of format. I've compiled a list of questions on a handful of topics that I'm going to ask her. She does have some slides that we're going to share with you all as well, but this is really going to be like an interview. So I'm going to ask the first question. If you all have any follow-up questions, please use that raise hand icon. We'll unmute you and let you speak. But first, to get a sense of where you all are in implementing your screening in SDOH, we're going to ask you a polling question. I'm going to pull that up. Chantel, will you help me read this once it comes up?
Can you rate your degree of difficulty in integrating SDOH into your EHR? This is on a scale of 1 to 5, with 5 being extremely difficult.
Okay, thank you. I'm going to end the poll.
Okay, 25% of our participants reported a score of 1, 50% of our participants reported a score of 2, and 25% of our participants reported a score of 3, and we had 0% of our participants reported a 4 or 5 or not applicable.
Thank you so much, Chantel, and thank you all for answering that poll. It really gives her an understanding of where you all are and how much information to provide. So welcome, Zara. Thank you so much for being here today, sharing with our audience. The first question for you is to hear a little bit about La Maestra, your patients and your community, and the circle of care model that you've developed, how it's a good model for integrating SDOH into primary care.
Thank you very much. If you could share the first slide that shows the, yes, there we go.
Okay.
Oh, thank you so much for this opportunity. It's always great to share our journey and of course, lessons learned. Hopefully it could help the audience. And I look forward to their comments and questions and learning from them as well. La Maestra, just to give you a little background of how we evolved to this holistic model. We started in 1986 as a nonprofit educational facility that provided education, civics, history, amnesty assistance to about 12,000 students. And that's where, you know, through that program, we had a student council that met every month, and they were identifying the challenges that they had, needs that their community had, their families. And so we responded by growing many of these services, oftentimes within our organization, and also working to build network collaboration, reaching out to other nonprofits. For example, when we started our children's program, We reached out to organizations in San Diego area that were providing, you know, the Head Starts, well, this actually before the Head Starts, and trying to collaborate and share resources, obviously. So that's one example, you know, of sector networking. Another was with our legal and immigration services through the Amnesty program. We assisted 12,000 applicants with their immigration applications for residency, and then went on to citizenship, all kinds of adjudication applications, political asylum. And those are services that we continue to today. Economic development was another one that we started back under the Amnesty program. And that is, you know, through our microcredit, micro enterprise, job training. So that got us to build more collaborations with workforce development in San Diego. And it hasn't been smooth because we know that funding and resources provided by the federal government, local, state agencies isn't always, you know, forthcoming with funds, and eligibility requirements sometimes are way too stringent, you know, requiring a 12th grade English proficiency level to even participate in the workforce training programs. So that's why La Maestra started developing programs around what is now termed as social determinants of health, because there weren't enough resources in the community. Same thing with the food pantry. We started maybe 20 years ago, just collecting food from different churches and different entities. And finally, we got connected with the food bank, Feeding America, and so on. And now we're a super pantry, and we also offer hot meals. So that's an example of how our program started in 1986, slowly evolving in response to the community needs, where there weren't enough resources out in the larger community. The health center started in 1990 because, again, the student council said, look, you know, we need a place to bring our family, our kids, and someplace that understands us, that speaks our language, that has staff that look like us, that have been through the same difficulties and challenges that we have faced. And we trust you guys. So could you like look into providing health services? And we were all teachers. We didn't know much about, you know, providing healthcare services, but we did learn. And in 1990, we actually established our nonprofit community health center, then became an Fqhc, and have been just adding a lot of very comprehensive services, as you can see here on this circle of care. It's a very holistic model, and it integrates those social determinants into primary health care. And as we move into the, you know, the system that we use to track SDOH, the workflows, you'll get an idea of how we got there through many lessons learned by experimenting with other platforms. So if we can go to the next slide, we can talk a little bit about our populations. Before then, I guess we get to the definition of social determinants of health. And this is a slide that I don't think you can see the bottom, but I borrowed it from Kaiser. And you know, one of the difficulties that we've had with our managed care health plans and with, you know, funders in general is that the definition of SDOH changes. And it's really difficult to have a common definition. This is one on the left side. But how does that translate into what diagnostic codes will we be able to utilize that are set by managed care health plans to be able to then hopefully eventually bill for those services we're providing under SDOH? So part of our role as Fqhcs and, you know, community providers is that we have to do a lot of advocacy with framing basically the, you know, what we know are needed services for our populations. And that's what we're doing on a daily basis. So if we could go to the next slide, these are, we did some research studies at La Maestra around the value that participants, patients, clients found in these integrated services. And to do that, we thought, well, first thing is, make sure we know who our populations are and what their issues are. And through our fantastic staff who are, representative of the populations we serve, we were able to put this together. Vulnerable populations, they're basically all low income. They fall into different categories, sometimes, numerous categories. And if you add that to adverse social determinants, as you see there in the middle, you start seeing the complexity of challenges that our populations face. And then add that on to prior adverse life experiences, because many of our populations come from trauma, backgrounds, whether they, are refugees, they were previously incarcerated, they had early childhood, abuse. Many of them recently have now been coming across the border, traveling for months and months and experiencing very adverse situations. So this is why, if you look at the circle of care, you can see, why did we develop the Human Trafficking Assistance Program? Because that's who, we started having a lot of populations years ago, even that basically were isolated, marginalized. There weren't programs for them. They did feel isolated. Then you take COVID on top of that, and it just adds more of anxiety, depression, feelings of hopelessness, until they, and this is what we found in the research that we did, was that when populations who feel isolated, they feel hopeless, they don't know where to turn, when they get plugged in through any of those doors in the circle of care, they then realize there's a support system there. And the more of the frequency of visits, the more trust develops, the more ability to find the resources, draw down the resources from the network that La Maestra has established over 35 years. They start feeling more confident, more willing to explore options for treatment, for example, where many of the populations, they're not going to come into the medical facility or right away and say, I think I have a problem with depression right away. That comes sometimes later, or it comes through other programs that they enter. Could be through the microcredit, could be through the youth development program. And they will have that relationship already established with the staff, and they'll confide, and then you can do the warm handoff, you can do the referrals, and it just seems to flow a lot better. I'm not saying that, that you can never screen and get all the information just by going into the medical clinic. You can, but it's really enhanced if there are other doors and other ways of obtaining this information. And that also applies to the screening for SDOH that we'll talk about in a minute. So if we could go to the next slide, that would be great. Give you an idea about La Maestra's populations. We have over 300 languages, 300, hopefully not, 30 languages every day. And that's already available with the staff that we have, very culturally diverse. And this number actually 500, we're over like 635 employees now. La Maestra developed early on what we call cultural liaison model. And what that is we have, from every culture and background, we have leads that are cultural liaisons that are cross-trained. They're usually MAs, PSRs, referrals. They work in myriad positions at the clinic and in the organization. And they really serve as a conduit to not only impart information related to resources, but be that person that the patients align with. They welcome them. Oftentimes they work in outreach, promotoras, and so forth. And they also, these medically trained cultural liaisons also then are able to educate our providers, our other levels of staff, as to what the trends are with our patients. What are the barriers could be related to misperceptions of, for example, I'll give you an example. One of our refugee groups that came in, they had learned in the refugee camp that diabetes testing actually gave the disease to people. So without that knowledge, we wouldn't have been able to successfully encourage them to, come in for preventative care and get screened and basically be tested. So that's just a small example. There are numerous more about how that conduit needs to be there for a constant education, information sharing both ways. Very important. Cultural liaisons are also very essential when we're working with special populations. And we want to ensure that that trust gets built right away, that there's an understanding that the information is imparted that's, that's culturally correct. And what do I mean by that? It's not just the language, it's the shared background. So who do we have working in our outreach teams for the homeless? Many times are people who were homeless that have now chosen, it's their passion to get involved and help others that were in their same shoes before. And with training, we bring them with our outreach teams, and it's extremely effective. Same thing, same model with the working with people that are in recovery or searching for recovery. We have in our BPHC, which is a certified community behavioral health center, that encompasses all the behavioral health, mental health, through counseling, medication-assisted treatment, and transitional housing. We have staff that have gone through that journey of recovery and gone on to get their, their certificate in drug and alcohol, and many other job opportunities there. And it's so effective because when patients come in, again, they're dealing with staff who understand them, who really empathize, yet can offer some really good advice and help them, mentor them get through their journey. And so also with the correctional facilities, re-entry programs, same kind of dynamic.
Can I ask a question? Oh, sorry, that was my mic. Abdeen had a great question, and I did too. The way that you speak about cultural liaisons sounds very similar to community health workers. We have a few community health workers that have joined today. Can you talk a little bit about how those roles are different or they're similar, and why you all kind of went with this cultural liaison title as well?
Well, we also have, because we've received grants for promotoras, community health workers, it's all based on the same philosophy of what activities they do, how they reach out. What we've done is because we've always had a very culturally diverse population and special populations, we went the extra mile to say, okay, it's great to have the promotoras and the community health workers, but we do need to make sure that we're representing the populations we're serving on our staff, and we're growing the future staff from within the community. And so that's why we went to the cultural liaison model, kind of one step up, and also offered, the training depending on what areas they wanted to work in. So, if they came in as a promotora and they really wanted to go for their, to become a medical assistant, we did that cross training. We made sure that we partner with different, certification training programs if we don't offer it ourselves, And so it's a way to continue the development of the community as far as economic development, as well as being extremely effective with the populations and basically encouraging them to access those needed resources.
Great. Do you want me to go to the next slide, Zara?
Sure. So just briefly, we did already touch on some of the programs that La Maestra Circle of Care has expanded to because of the need. The food pantry, economic development, financial literacy, housing assistance, transportation, nutrition, exercise, and a center for youth development. And we also have seniors that participate in the microcredit programs as well. Next slide. This is more of the same and different aspects of that.
Okay, so now I'm going to switch over. Can I ask you to describe how a patient who comes in with behavioral health needs, either maybe through your trafficking program, would be identified, tracked, and then cared for using your model circle of care?
Well, this has been really difficult, I have to say, first and foremost, to not just expand and actually develop the services, but integrate them into a seamless system. So let's say, you know, that somebody's going into the human trafficking unit and they do the screening for them. By the way, all the screening is basic now. We have basic screening guidelines in all of our programs. We didn't before. Each one had their separate screening process. The data was entered into a separate system that didn't communicate with, you know, with a general centralized system. As I said, it's taken us quite a few years to find the solution to not only, you know, where do you screen, who does the screening, what happens to that data. We don't just screen to be able to collect data and do nothing. We have to take action. So whenever we're screening, we have to make sure that there is a resource for the referral of that patient or that client. And that, I believe, is the responsible way to go. And at the same time, you know, explain to the patient and client that, you know, we're doing the screening process to see what other needs they have, and we'll try to match them up internally or with our partners externally, follow the referral, do the case management. But oftentimes there are waiting lists out there. There are not enough resources. So we want to make it clear to not build a false expectation among our patients just because we're collecting the data. And so if somebody walks in, for example, to our behavioral health, which I believe your question was, we provide the set of screening protocols that each one of those programs under our integrated behavioral mental health model provides. And we've developed the workflows. It captures the social determinants as well as what their needs are today, why they're presenting, right? And this information then is captured, and it right away generates referrals to our other departments. So if, for example, somebody who's coming in for the behavioral health has also identified themselves as a victim of violent crime, that goes to our legal assistance program right away. Depending also on the risk assessment for our patients in the behavioral health, you know, those that are high risk, we have other protocols in place, obviously from a clinical perspective. But around the social determinants, they're registered, information is taken, right away they're hooked up with their referrals, their case management, and it's the same in every unit now. Before it wasn't, and there was no way to really integrate the data and have that case management as a centralized model. Each unit had its own case management back, you know, before, and we still do, But there is another layer now. If you could look at the circle of care inside, there's a circle inside the circle, and that I would really identify as being that advanced case management. And I'll give you an example when we get to the health homes program.
Okay, great. Thank you so much. I want to ask you about, your staffing for your screening, because you mentioned the cultural liaison, there's the providers. What types of staff are involved in the screening process? How have you adapted your staffing plan to screen for SDOH? Can you talk a little bit about what worked before, what didn't work, what works now, and how you all kind of went through that process?
Well, we thought before that, we should appoint, one unit and try to do the screening through that one unit. Quickly, it was obvious that we needed to train all levels of our staff to be able to understand the importance of addressing social determinants and the factor that it weighs in for the towards well-being of the patient. And so we had to do a lot of staff training, from our PSRs to our outreach staff, providers as well, because patients aren't going to all divulge information because of the reasons you mentioned before. Could be, culture, the stigma, could be that they feel ashamed, that they feel shy. They don't really trust yet the person that's asking them these questions. And so that's why it's important for all levels of our staff to understand the importance and be able to capture that information.
Here's your slide about the home.
Okay, so I wanted to mention, we're here in California, and the state DHCS developed a CalAIM initiative, and through that, they wanted to really address like whole-centered care, whole person care. And the first program that really was adopted here in San Diego through some of the managed care plans is called Health Homes Program. And very small subset of our population, if you look at the larger population, qualifies to be eligible. Basically, the health plans decided to pilot this program to see if they could reduce the cost for the highest utilizers of their members. And those were folks that had, visited the ER at least one time, had chronic disease, mental health issues, behavioral health as well. And so for the members of the health plans that fit this criteria, the health plans then were going to pay, and they are paying, reimbursing for some of these SDOH, like the case management, housing navigator, and so forth. So it's kind of like a mini circle of care, but for only specific qualified health plan members. And so La Maestra, since we were positioned with our circle of care and already were offering the SDOH, we right away joined their pilot, and we've been really successful with expanding that case management model, the central piece, working on further technological advances with our EHR that we're going to get into in a minute. And work through some of those challenges that still plagued the integration of the system of the SDOH. So this was great, and we are now seeing that CalAIM is going to adopt what they call expanded care management, and for more of their members. So it'll be like this, but for more of their members, as well as ILOS, which I don't know why they called it that, in lieu of services, meaning it's in lieu of medical services. This is the social determinants. I wish they would have just called it that. Anyway, that's where we're moving towards, and they still don't know how much they're going to reimburse. We are at least at the table and are able to provide our input as to, how much time does it take to work with clients, to do the case management, to do the follow through, to arrange for the transportation, the translation, housing, eligibility, just the numerous services. And then I'm sure it's going to be a continued dialogue with the health plans. But definitely they're moving in this direction because they have seen through HHP, which was the pilot, the Health Homes program, that they're saving money by connecting their members to a medical home that has the capacity to address SDOH, either in-house or has the collaboration network built. Okay.
Okay, thanks. I want to switch to, we've talked about this, about, your community network. I want to ask you to talk a little bit more about it. But before that, I want to ask folks on the call here if they could describe how developed their community referral network is. I'm starting a poll. Chantel, can you help me with this poll?
Sure. How developed is your community referral network? Are you in the beginning stage where you've mapped potential partners in your community? Are you in the intermediate stage where you've created an informal network of community organizations to refer your patients to? Or are you in the experience stage in which you have a referral systems where patients can be tracked and outcomes can be monitored whenever they receive services outside of the clinic? Or it's, I don't know, or not applicable?
Just going to give you a couple more seconds to answer. Looks like we only have one person who's answered the poll. Okay, I'm going to end the poll.
Okay, 50% of our participants indicated that they are currently in the beginning stage, and 50% of our participants have said that they are in the intermediate stage.
Okay, thanks so much for that. So the question, Zara, is how to do that. How have you been able to build up your community network? And if you have any advice to these guys who are in the beginning and intermediate stage.
Yes, I think that, working across sectors is really important. Many healthcare providers have generally worked within the healthcare industry. They'll have fantastic collaborations, networks, coalitions, but all within the field of health. And building this collaborative network to be able to refer patients to housing and food scarcity programs, economic development requires developing the network outside the healthcare sector. And oftentimes, I've given presentations and people ask, okay, so like, what's the best way to start that dialogue? What kind of agreement should there be in place? And what we've found is that, you have to be able to reach out and across sectors and connect to those resources in the housing field, in the economic development field, in the food, scarcity and so forth, to find the resources. So we're not just socially prescribing without knowing that the referral will lead really to a program that can help our patients. And to do that, you have to figure out what's their eligibility requirements. Do they have capacity and how many? And that all can be worked out through a basic MOU that, like we have as Fqhcs with our local hospitals and many other partners. It's just a memorandum of understanding that, and to build that, you'll know you'll have to talk about, what's your capacity and how many people can you take and what documentation are you going to ask for? What's the eligibility? So that really goes hand in hand with developing those resources. It's not just handing the patient a list that you pulled from the internet and saying, go look here, because it leads to a lot of frustration. And patients that have these, they feel like they're submerged with all these complex issues, and then to send them around on a bus to find out, only that they don't qualify or there's no more room, it's hard. And I understand that, that the health center staff is already taxed with a lot of work. I understand that. But if we want to develop these collaborations, we have to put forth that, that incredible effort and get these MOUs in place and understanding so that, and you're basically reassured that where you're sending them, if it's external, that they have capacity. Again, the reason that La Maestra developed many of these services years ago was because there wasn't enough resources out there. And so right now we use a hybrid model where we have many of these programs in-house, and so it's easier for us to control. We're going to be able to have that repository of data once that patient does take up that referral, goes to that other program within La Maestra's circle of care, and that information is then inputted into our case management in our system, right? Getting the information back from outside referrals is really tough sometimes. Different organizations have various rules around sharing data. And so those are hiccups that you're going to have to work through. We did. And it's a constant issue.
Okay, thank you so much. You answered all of my follow-up questions about data sharing and how to, Dean asked about accountability and follow-up and how those sectors are reconnected back to La Maestra. I'm just looking at the clock here. We are at the hour, and I know there's a lot more that Zara wanted to share. Oh, here's her slide about the network. Zara, do you want to share your EHR slides and talk
Sure.
about that briefly, or we can move it to next week, but maybe just.
Well, we can go to the EHR. I just wanted to share, for those of you that are looking how to capture your social determinants data, we wanted to basically expand our EHR. We use NextGen, and the system would only let us capture medical, clinical services because those are the fields that had been built by the vendor, right? And so we developed another system on Salesforce, and then yet another one on QuickBase. And finally, we got to convince the vendor to have us purchase, help us purchase another practice within our enterprise. So if a patient comes into La Maestra, and let's say the provider pulls up the screen under EHR NextGen, there's going to be a tab. So here you see the practice. You can choose La Maestra Community Health Centers, or you go into the practice of social determinants, but it's still on the same EHR. Go to the next slide, please. And I don't know if you can see from here on the left side, you can see if you're in the clinical portion of the practice, then you can easily choose from within there. There are tabs that get you over to the social determinants fields. So you don't have to exit your clinical EHR to log on to another system, because we tried that and it won't work. It takes up way too much time and it's not integrated. Next slide, please. And so then we just put this to show how easy it is then for the providers and for the staff to toggle between the two practices still under the same enterprise. Next slide. And so again, and this is the training basically that we work with our providers and all of the staff on, because staff's going to be like, oh my gosh, you mean we're going to have to get onto another system? No, here, let's show you, get the monitor up and have these meetings and reinforce the reasons why we're collecting the data, and how easy it is to use. Next slide, please. So here gives you an idea, you can be in the medical or SDOH practice, and you can do the referrals from both, which is awesome. And then those referrals go to the case management. Now, we did already have our social determinants workflows and data fields selected, and then we were chosen to be the pilot under NACHC prepare pilot model. And so we went through phase 1 with them. We did modify what they had come up with to fit what La Maestra's workflows are around our circle of care. Next slide, please. And so when you're in the patient chart, you can view both the medical and the social determinants referrals, which is really important. So let's say that provider had referred the patient to human trafficking assistance or legal or transitional housing or any of those other services. When that patient comes back in, they can see that what happened. Did they go? Is there any data there? And get in contact with that case manager that was assigned to that patient for follow-up. Just like they would outside medical referrals, clinical referrals to specialists. Next slide. We have developed our own SSRS templates so that we can try to develop, get into the weeds here, more specific information about utilization. How do we tie it to our HEDIS? How can we establish not just the connection to quality and what what difference did it make that we have all of these social determinants on the quality metrics? And so, I mean, we could do a whole presentation on that. And also now we're doing studies about ROI, return on investment, to be able to show the different agencies and funders, look, and managed care plans, we're saving money by having these social determinants integrated into primary health care. Aside from, the humane way to go, which is to bring well-being into people's lives, right?
Mm-hmm.
Next slide.
All right, thank you so much, Zara. This was great information. We can probably continue the conversation that you started about quality and ROI next week, because you're going to be talking to us about reimbursement and evaluating our impacts. Thanks to all of you all for staying on the call. I just want to mention this. I tried to bring it up last session as well. There's an emergency broadband benefit program that's available to your patients. It provides reimbursement for their internet fees. And so I encourage you all to explore this for your patients. I think it's a really great program that started in May. Here are the resources that we described today. And if you have any items that you would like to discuss in our next sessions, just let us know. I'd like to launch the evaluation poll. And I want to thank Zara again for her wonderful presentation and for all of that she shared. And thank you so much for joining us today. If you don't mind, please filling out this evaluation poll, and we will see you next session on the 15th.
Thank you.
I'll keep this open for just a minute. Okay, I'm going to end the poll. All right, thank you, everybody. Thanks so much. We'll see you next time. Thanks,
Okay.
Zara.
Okay,
Bye.
have a good day. Bye-bye.
Bye.